Virginia, the first question is for you, and it's a sort of a technical problem. One of our colleagues in the audience is asking, in case of nocturnal hypoglycemia, how, let's say, reliable could it be a false hypoglycemia due to the pressure or due to the wrong reading of the system?
Yeah, we can have that problem, but the picture you see in the graph is really different from that. I mean, you see like all night with a red value, so it's not so common, and you see a different picture in the AGP report.
And a question is for Ramzi. Ramzi, what do you think is the right approach for intermittent use? You mentioned at a certain point in your introduction.
Yes.
What does it mean, intermittent?
So, okay, I need an hour for that, but I will summarize it in a few seconds. Yeah. So people who are stable, you may want to do that 2 to 3 times a year just to make sure there is no hidden hypoglycemia or unusual levels. But when you're changing therapy is when it gets really useful. So you change therapy, you continue with the CGM until they are stable, and then you revert back to using the sensor anything between 2 to 4 times a year if things are absolutely stable. But of course, it is patient dependent, and you may need to do it more frequently, but change of therapy would be very, very helpful to do it then.
Thank you. Robert, you mentioned hypoglycemia and the risk of cardiovascular disease. How do you define that hypoglycemia? And if there is any specific trigger for hypoglycemia to give that kind of outcomes?
Well, I think, as we've seen through these cases, the hypoglycemia, which is well, illustrated on the AGP readings, can, is often due to the treatment of the diabetes, and as we saw, can be easily addressed by adjustment of therapy, including these patients with cardiovascular disease. Obviously, in cardiology, we're focused on a number of the drugs that are also associated with cardiovascular risk reduction, such as the GLP-1 agonists and SGLT2 inhibitors. And we've seen cases there where the Freestyle Libre readings have allowed a focus on those treatments that to improve glycemic control, reduce variability, and reduce hypoglycemia.
Yeah, one more question for Virginia. Virginia, you've discussed a case or de-escalating from insulin, introducing insulin. What about people in the early stage of their disease where there is no insulin and actually maybe very beginning, very the start of the disease? Is this a sense for using a CGM?
Yeah, of course, I think there is a sense for using CGM because it's really helpful to target diabetes education, and so the patient can understand how certain foods act on glycemia, how the exercise acts on glycemia. So it's really helpful for the patient to understand their diabetes.
Very good. I think that, we have all the questions. I'm checking if there is anything else. But I think that we have dealt with all the questions that we have receiving, and actually we come to the end of the hour. So I'd really like to thank all of you for being here. We've been discussing about revolutionizing the treatment of diabetes, but if you think carefully, there is no revolution. It is an old knowledge that comes from a big philosopher, Socrates, and used to say, know yourself. So if you want really to know yourself and you have a diabetes, you need to measure your glucose. And you need to be not just measuring the glucose once upon time, but really to realize what kind of a treatment or kind of a achievement you can get. So I think it's just a fantastic tool that we have in our hands to help many people with diabetes. And for that, I really like to thank Abbott for giving us this opportunity to discuss this new technology. Thank all of you for being here. Thanks the speakers. And I really like to wish you a very continuation of this EASD 2024. Have a good day.